Okay, I want to thank everybody for joining us tonight. We have another installment in the Vibrant Educational Webinar Series, and this evening we are incredibly excited to bring on Dr. Kathrine Kubovy, who is going to talk to us tonight, delve into the subject of thyroid and autoimmunity. A little bit about Dr. Kubovy. She has been a practicing chiropractic physician in Kansas, here in my metro area, and I've met her in person. She's absolutely wonderful. She's licensed in Kansas, Missouri, and Nebraska. She has a specialty actually in diagnostics and management of internal disorders. And so just a little bit more about her. She has really kind of niched and specialized in the internal medicine or internal disorder, as well as laboratory interpretation and the use of those in her practice. And so she is such a fabulous resource for this particular topic, dealing with thyroid and autoimmunity, and she has so much experience in that field. So I'm gonna go ahead and introduce her. As always with our webinar series, if you have any questions during the webinar, there is a Q&A box on your screen. If you're logged in online, it gives you the opportunity to type a question. We're going to hold the questions until the end of the webinar, and then we'll have about 10 minutes or so to kind of get some of those questions answered for you. And then I will go ahead and turn it over to Dr. Kubovy. We are so excited to have you here. So again, I just want to thank you for your time tonight, and go ahead and jump right in and tell us, a little bit about yourself and get started.
All right.
I'll let you share your screen.
Well, did it go?
So we see the website. You might have to change to.
There we go. Do you see the slide?
Perfect. You're good.
Wonderful. Hello, everyone, and welcome. And thank you for joining us on this Tuesday evening. Sarah, thank you for the lovely introduction. And as Sarah said, I am a chiropractic internist. I am a functional and integrative specialist in the chiropractic field. And my scope of practice is natural. So I know we have all different providers, all different types of providers, all different types of specialists. And everybody has different treatment methodologies and scopes of practice. So here's what we're hoping to cover tonight. I would like to do a basic overview of thyroid physiology, then get into looking at integrating the symptomatology and findings so we can consider how a patient who comes in for a seemingly unrelated condition might actually have a thyroid issue. And alternately, sometimes we see patients who think they must have a thyroid condition because they have every symptom in the book, but then they've been tested and told they're fine. Luckily, we have all of these wonderful Vibrant America diagnostic tools to dig into the meat of these really sometimes very complicated cases and have positive outcomes for our patients. So hopefully everyone here can take away at least one little nugget of information to use in practice. So I'm going to motor through the slides as fast as I can so we have Q&A, but here we go. So the thyroid is located on the front of the lower neck. It produces thyroid hormone, T3 and T4, and those hormones affect virtually every single tissue in our bodies. Iodine is extremely important for thyroid hormone production. We ingest iodine as iodide, and the iodide is organified by thyroid peroxidase. Then at that point, the amino acid tyrosine that you see up here is iodinated, and that reaction will produce your T1 and T2. The T1 and T2 are then coupled to produce T4 and T3, which we're all very familiar with. That all happens while it's still incorporated in the thyroglobulin. After that, T3 and T4 are cleaved from the thyroglobulin molecules and sent off into the bloodstream. The vast majority of hormone released into the bloodstream is T4, and most of our thyroid hormones are bound to a carrier protein. It's called thyroxine binding globulin, and then that carrier protein transports to the tissues. As the name implies, thyroxine binding globulin, has great affinity for T4. So although we know T3 is much more biologically active, it does not travel well. So our bodies will convert the T4 to the T3 in the periphery with an enzyme called 5' deiodinase. 5' deiodinase will clip off an iodine from T4, creating T3. Then your T3 can bind to nuclear receptors in the cell and trigger that genetic transcription, which will create proteins, enzymes, and the like. There's really very little free thyroid hormone in our bloodstream. Only about 0.3% of total serum T3 and 0.03% of total serum T4 is actually that free component. We can store our thyroid hormone for about 3 weeks, so that might be a therapeutic or a treatment consideration for you. So here's the basic feedback loop. The thyroid is controlled primarily by TSH, which is secreted from the anterior pituitary gland in our brain. The anterior pituitary gland responds to stimulation from thyrotropin releasing hormone in the hypothalamus. There's a negative feedback loop from the thyroid hormone concentration in the peripheral tissues that goes back up to the anterior pituitary to either stimulate or halt TH secretion. It is very, very important that we note that thyroid is a respond-only gland. So we, especially in functional integrative medicine, sometimes we'll see some cases of primary thyroid failure, but typically we'll see the secondary and tertiary and concomitant causes of thyroid failure. So if a person is in a terrible car accident and their obturator artery is severed, that kills the blood supply to the thyroid, that would be a perfect example of a primary thyroid problem. But that is not typically what we see, so we're going to focus more on those other mechanisms. Increased levels of T4 and T3 inhibit that TSH synthesis and secretion, and vice versa. A little note, we all know about reverse T3 down here. Reverse T3 is a hormone that can be produced. It's actually an inactive isomer of T3, but it competes for the T3 binding sites. In a functional normal working system, this is a protective mechanism. So it will prevent sudden changes in T3 concentration, which could be potentially damaging to tissues. And in this webinar, we will talk about other reasons why that reverse T3 might be produced that might be a little less normal. And so more on that later. So let's talk about how the thyroid gland influences our other body systems and how we can kind of integrate this awareness to determine what the patient really has going on. They may have something, like we talked about, similar, seemingly unrelated, but there might be a subclinical or overt or autoimmune thyroid condition that is a complicating factor or potentially a primary issue. Let's talk cardiovascular first. Under normal circumstances, thyroid hormone should increase the overall metabolic process. So when we're talking about the cardiovascular system, we see increased blood flow, increased cardiac output, and increased heart rate. And this all makes perfect sense. When we increase metabolic activity, there is an increased demand for oxygen. There are increased metabolites from the cells and cellular processes. There's increased demand for nutrition and energy, and so forth. Thyroid hormone actually strengthens the heart, and it also decreases peripheral pressure because it relaxes smooth muscle. There's a little clinical tidbit here. You do see an increase in pulse pressure when excess thyroid hormone is present. And that can be up to 15 millimeters of mercury on the systolic pressure and up to 15 millimeters of mercury decrease on the diastolic. So it's very easy to note that change in vitals. Heart rate is also very interesting. It's highly sensitive to increases or decreases in thyroid hormones. So it's a good thing to look for. So a few of the related cardiovascular conditions we see pretty regularly in practice are atherosclerosis, high or low blood pressure, metabolic syndrome. And actually, I'd take it a step further and say any form of blood sugar dysregulation, even prior to metabolic syndrome, may be a factor there, as well as anemia. Interestingly enough, iron deficiency slows the conversion of T4 to T3 because it acts on those deiodinase enzymes. And an iron deficiency can actually also increase the production of reverse T3, which can create some problems. So on to GI. Again, under normal circumstances, the thyroid hormone should influence carbohydrate metabolism. This would mean increased uptake of glucose, glycolysis, gluconeogenesis, increased absorption from the GI tract, and increased insulin secretion. And this would all be due to increased enzyme production from thyroid hormone acting on the nucleus of our cells. So lipids are also mobilized from fat tissue, which eventually results in more fatty acid elimination in the feces. So that's a good thing. The basal metabolic rate increases, and that will increase the speed of breakdown and absorption and assimilation of nutrients and elimination of waste. That would be on both the micro and the macro level here. And the thyroid hormone increases the need for vitamins. But clinically, this is important too. We need to be aware of relative vitamin deficiencies. If thyroid hormone is going to upregulate our cell metabolism, there is an increased need for the vitamin cofactors, because that's the whole point of vitamins, to make all of these processes work. So when practitioners might be intervening to increase a patient's thyroid function, there's an increased need for vitamin intake. All of these related conditions here can be impacted by thyroid function, and coincidentally, and some are also symptoms and signs of thyroid dysfunction. So let's talk about what happens due to our sex hormones. Thyroid hormones have a direct impact on ovaries. They also indirectly will impact sex hormone binding globulin, prolactin, and gonadotropin releasing hormone secretion. Statistically, we all know women are dramatically more affected by thyroid conditions than men. And it is likely has a lot to do with hormones in pregnancy. But another possible contributing factor is that women share their iodine with their thyroid, their ovaries, and their breasts. That ovary and breast tissue takes up a lot of iodine. And so that might be a consideration there. These are a few of the conditions we see that might have a thyroid cause or contribution. Precocious puberty, that would be because thyroid hormone acts on ovaries. Menstrual issues, fertility issues, and abnormal hormone levels in men. A clinical note on fertility. For hypothyroid women of reproductive age, so 20 to 40 or so, autoimmune hypothyroidism is the most common cause of infertility. This is very important for practice. We see infertility rising. So it's a good thing to be aware of. And another side note with respect to female hormones, estrogen has a major affinity for thyroxine binding globulin, which is the transport molecule that takes thyroid hormone from the thyroid to the peripheral tissues. That transport protein is created in our liver. So when our estrogen goes up, the liver will increase the thyroid binding globulin to offset or to compensate, and that will result in more bound thyroid hormone. This could be a mechanism for a functional or subclinical hypothyroid condition. So you might want to consider this if we're talking about a case of estrogen dominance, progesterone deficiency, birth control, hormone replacement therapy, menstrual symptoms, obesity, the list goes on. Then this is a topic that is, I'm sure, very well known amongst all of you and very well known amongst most providers, but it's very, very, very important. Women of childbearing age should be screened for thyroid conditions because the effects of an undiagnosed thyroid condition can be absolutely devastating. The research is very clear. A mother with an untreated thyroid condition will have children with learning complications and potentially significantly lowered IQ. The risk for pregnancy loss for women with all types of thyroid conditions is very high. It really depends on where you look, but the research will say that the risk of pregnancy loss is increased from between 4% and 200%, depending on the thyroid condition. And cretinism is listed on here. It's rare, especially in the United States, but it's an extreme example of how hypothyroidism and severe iodine deficiency can affect a fetus. So on that unhappy note, let's talk about the HPA axis. The HPA axis, it modulates our stress response. So basically, in response to a stressor, the hypothalamus releases corticotropin-releasing hormone, which triggers ACTH, and the ACTH acts on the adrenal gland to release some cortisol. Elevated cortisol levels in the system will inhibit the hypothalamus and the pituitary on a negative feedback loop, the same way thyroid hormone inhibits TSH secretion in the anterior pituitary. So as you all know, cortisol is our stress hormone. In the short term, cortisol lowers inflammation in the body and increases carbohydrate metabolism, which is fine. It also triggers a cascade of other chemical triggers, if you will, like epinephrine, norepinephrine, and that will stimulate a typical stress response. So our heart rate will increase, cardiovascular tone is another consequence. Pupils dilate, cognition improves, we're a lot less sensitive to pain. So in the short term, this is fantastic. However, if the stressor is not removed, this pattern will develop into adrenal dysfunction, which will eventually lead to HPA axis dysregulation. So cortisol is our major stress hormone, which has some wonderful short-term functions, but then things need to go back to status quo. The takeaway here is cortisol is meant for crisis management. Clinically, I should note that not only does cortisol remain elevated with our typical mental or emotional stress, but when there's an infection, if there's been a surgery, a chronic illness, a sedentary lifestyle, all of those things can keep cortisol chronically elevated. So here's where it gets even more interesting, at least with respect to tonight's topic. High levels of cortisol are going to decrease thyroid function by decreasing the conversion of T4 to T3 by impairing deiodinase enzymes. It can also increase reverse T3 production by acting on different deiodinase enzymes. And although that reverse T3, we already talked about it, it is biologically inactive, but it screws up that negative feedback loop to the anterior pituitary. Our systems are not quite sensitive enough to recognize the difference between the reverse T3, the inactive isomer, and regular T3. So when this happens, that useless reverse T3 can cause a decrease in TSH production, which results in a less functional thyroid hormone concentration. So I tell patients all the time that our body has no idea if we are running from a tiger or having a really bad day at work. The chemical stress response is the same. Those spikes in cortisol and the excitatory neurotransmitters that come as a result are very good at keeping us physically safe or handling an occasional bad day. But it is far more common, at least in my practice, to see chronic, unrelenting stress patterns in our patients. When this happens, it can lead to a whole host of problems that we generally refer to as HPA axis dysfunction. And this is, HPA axis dysfunction is certainly something we can measure and treat. But again, when we're talking about thyroid and integrating the body systems to figure out the best course of action for our patients, this can be of significant importance. And as I'm sure everyone knows, cortisol is diurnal or circadian, so it's going to be higher in the morning and then taper off as the day goes on. if we measure this and this is not the case, then we've got some problems. So let's figure it out. In practice, we tend to see more cases of hypothyroidism than hyperthyroidism because hyperthyroidism is simply less common all around. Then we have autoimmune thyroid conditions, and we'll get into more detail here in a minute, and that can throw a big wrench in the mix. Most of our hypothyroid cases present with symptoms like fatigue, weight gain, constipation, dry skin, hair loss, depression or anxiety, and menstrual issues if they're menstruating. Most of our hyperthyroid cases are hot, they're anxious, they're depressed, they're having very frequent bowel movements, they don't sleep well, and sometimes we even see the exophthalmos, the bulging of the eyes. And to make it more complicated, autoimmune thyroid conditions may have a combination of the two. So that's what we see subjectively. Then physically, when we do the exam, and we see myxedema, that's a hallmark of hypothyroidism. That's a big change in swelling and increased mass of the tissue, usually in the face and on the anterior tibia. When the lateral third of the eyebrows is missing, that's another telltale sign of hypothyroidism. Hair loss can be common with either one, hypo or hyperthyroidism, and so can goiter. Now, one thing we see with hypothyroidism is we see scalloping of the tongue and macroglossia. So when they stick out their tongue, it will be scalloped on the edge, kind of like a pie crust. And they'll almost always say their tongue feels too fat for their mouth. So we all know people who have this periorbital edema, those really big bags under their eyes that never go away, no matter how much sleep they get or what cream they use or what they're doing. Now, exophthalmos, that is referring to these bulging eyes, and that's certainly more commonly seen with hyperthyroidism. We also with the dry skin. That's the thing I wanted to point out, because clinically, when I'm doing exams, I find it easier to look at the heels for dry skin because hands can get dry depending on how much you wash your hands and things like that. But especially in the summertime when patients are wearing heels, you can just eyeball it pretty easily. Our hyperthyroid patients are frequently hypertensive. Oh, this is an important clinical note. The Achilles reflex is sluggish in 78% of undiagnosed hypothyroid patients. And in diagnosed thyroid patients, it's present 92% of the time. That is huge, especially those of us who are in physical medicine. Half the time we're checking reflexes anyway, so it might be a sign that you need to look further. Puffy face, an increased resting heart rate, and obesity all go with thyroid issues. I encourage all practitioners to palpate the thyroid and to get good at it. Typically, if it's inflamed and it's puffy, you can treat it. If you feel nodules or it's a full-blown goiter, I recommend referring out for imaging. But so many of these things are so easy to see the second you walk into the room to visit with your patient. So that's a kind of a blessing in disguise, I suppose. So here we go. Autoimmune thyroid conditions. Hashimoto's thyroiditis is one of the most common autoimmune thyroid conditions, and it is the most common cause of hypothyroidism in the United States. It is caused by a rogue immune response, and if you want to get specific, it's a CD4-mediated T-cell response, which causes infiltration and eventually non-function of those thyrocytes. And this can be caused by a genetic predisposition, an infection, a gluten or allergy exposure, other autoimmune conditions, some combination of the above. The research is still being collected on that. So patients will usually present with some typically painless thyroid enlargement and usually hypothyroid symptoms. But I will say clinician beware on that. Hashimoto's patients may experience hyperthyroid symptoms as the thyrocytes change and become more damaged. So as the condition progresses, we see a more consistent hypothyroid presentation. So in labs, we'll see the anti-TG elevate first, and then the anti-TPO will follow along with high TSH, low T4, and low T3. The anti-TG tapers off, and it leaves an elevated TPO. So if you only see elevated TPO, whether it's in the presence or absence of other abnormal thyroid markers, this is a chronic autoimmune thyroid picture. You have no idea how long that's been there. Those TPO antibodies are cell-mediated, meaning the TPO antibody response destroys those parenchymal cells over time. So catch it as early as you can. The severity of the autoimmune condition will depend on the time that's lapsed and the strength of the immune response. So as clinicians, our job is to calm the immune system. The T helper cells that mediate this will enter a type of dormancy if you can slow the immune response appropriately. So clinically, when we see other autoimmune conditions like RA, like lupus, eczema, psoriasis, type 1 diabetes, Crohn's, celiac disease, ulcerative colitis, and so on and so forth, then we really want to be making sure we're considering an autoimmune thyroid condition. We also need to consider chronic, low-grade, and stealth infections that might be contributing to an overzealous immune response. Things to look for there: Epstein-Barr, chronic UTI, undiagnosed SIBO, chronic sinus infections that never die, and so forth. So now we can talk about the other major autoimmune thyroid condition, kind of at the other end of the spectrum. And I say other end of the spectrum because although it's immune mediated, like Hashimoto's, it usually occurs earlier in life and is initially a hyperthyroid presentation. We'll see the elevated heart rate, we'll see weight loss, they'll be hot and sweaty, their eyes will bulge. Sometimes we'll see thyroid enlargement, a goiter, frequent bowel movements, diarrhea. We went over hyperthyroid symptoms. So the hyperthyroid symptoms, that's consistent with the beginning of the disease process. And that's because significantly increased thyroid hormone, it goes out into the peripheral tissues and acts. But eventually, the patients have hypothyroid symptoms because the thyroid will fail once it's infiltrated far enough. So to the provider, like Hashimoto's, we need to work the immune system. So you'll see abnormal thyroid markers in the lab, but the thing that's diagnostic and very unique to Graves' disease is that thyroid stimulating immunoglobulin. And Graves' disease, it's an antibody to the TSH receptors. So when it gets down to the nitty gritty, it does work differently than Hashimoto's thyroiditis. But if you're practicing from an integrative approach, you got to go after the immune system. So you can support your patient with things like selenium and sea salt. In some conditions, iodine might work, and a good vitamin regimen until you can calm down that immune system. When we are talking about any autoimmune condition, we need to consider gluten as a causative factor. Gluten is especially unique, or a unique culprit, maybe I should say, to thyroid conditions because that gliadin protein is quite remarkably similar to thyroid protein. So the body can't tell the difference between the two sometimes. So if the patient has a gluten issue, it can cause a thyroid issue. Or if the patient has an autoimmune thyroid condition, gluten can make it worse. I imagine everyone on this webinar is familiar with Dr. Fasano's work with zonulin. Zonulin is a protein in gluten that destroys those tight junctions in the intestinal epithelium, and that will cause intestinal hyperpermeability. And intestinal hyperpermeability is a mechanism for potentially any or all autoimmune conditions. And Dr. Fasano's work clearly demonstrated that neurological and psychiatric symptoms can also be gluten mediated, even if the patient doesn't have any overt GI symptoms. So when we consider the symptoms that typically go along with thyroid conditions like brain fog and anxiety and depression and lethargy, it's important to consider gluten as a big player in the picture. As we already discussed, when there's one autoimmune condition present, work on the immune system, look for more autoimmune conditions, work on the immune system for the betterment of those symptoms just across the board. So there are a few lifestyle and exposure considerations for thyroid health as well. There's a lot of research on there on relative iodine deficiency in the US. The US RDA is wildly lower than the average iodine consumption in Japan. In fact, it's 92 times lower. And it should also be noted that the Japanese have a very low incidence of hypothyroidism, and they have a very low incidence of breast and other feminizing cancers. So if you want more information on iodine, Dr. David Brownstein, all of his books are online, and he's a great resource there. We should also be looking at halide competition. So if you look down here at the old periodic table, those halides have a similar chemical structure, and they can competitively inhibit iodine transport, which will inhibit the iodine organification and ultimately prevent conversion of T4 to T3. Bromine is a big culprit because it's in all of our baked goods. It's also in sports drinks. So I would encourage everyone who's giving sports drinks like Gatorade and Powerade to children, or to themselves, but especially to children, to watch out. Iodine is very important because thyroid function is very important for the developing youth. We also have, of course, lots of exposure to fluoride and chlorine in our water. There are these medications that are listed here. Most of them, and there are certain name brands that are more effective than others, but many will increase TSH and decrease T4 and T3 levels in the system. Pesticides, unfortunately, can be absorbed through the skin and inhibit the binding of T4 to its nuclear receptors and actually slow TSH production. And PCBs and PBBs will specifically cause thyroid autoantibodies, and then red dye number 3 increases that inactive reverse T3. So let's look at some potential lab workups. The labs on this page can be done through Vibrant America or the lab of your choice. They're all fairly standard. I'm preaching to the choir here, but with respect to TSH, in the functional and integrative medicine realm, we appreciate that the normal range is really about 1.8 to 3.0. I certainly prefer a TSH under 2.5. And we need to consider, at least with our interpretation, TSH is circadian as well. It's considerably higher in the morning than it is in the afternoon. It actually peaks around 2 a.m. to 4 a.m., I believe. And so we probably want to take this into consideration when we're interpreting a fasting blood draw that was taken at 7 a.m. Normal total T4 would be between 6.5 and 12, and total T3 should be between 115 and 180. And we just finished talking about how we want to look at all of these thyroid numbers and how they relate to one another. If you have the thyroid antibodies present, you need to come at it from an immune perspective more so than a thyroid perspective. The workup totally changes at that point. If there's a conversion issue, if the reverse T3 is through the roof, it really changes the direction you take that patient. So when we're looking at ferritin, we can consider it as an acute phase reactant, and we can also look at it with iron levels to see if there's an anemia issue. We saw that earlier. If we're looking at B12, vitamin D, or really any of the vitamins, we're trying to figure out absorption, so it's that GI work that the thyroid does. We can also look at methylation and therefore detoxification issues of the B12, and the folate, which I failed to mention here, are off. So when we're considering a lipid panel, one of the things we can look for is actually insulin resistance. It's an early place to find it. That triglyceride to HDL ratio should be less than 3.5. If it is not, they are likely insulin resistant, and it might be a faster way to catch it than going through the full-blown sugar glucose processing panel. Not that that's not important. It certainly is. It's just a different way to look at it. C-reactive protein and homocysteine will give us clues about the inflammation in the body and some insight into methylation issues if they're there. On the metabolic panel, I would say if we're looking at thyroid, watch for catabolic processes that are kind of under the radar. So if a patient has low BUN, for instance, and low protein, it would indicate inflammation in the system because the body is trying to go through constant catabolism. So if that's there, find the cause. Figure out where the inflammation is coming from. CBC is a great place to look for chronic or acute infection. And as we discussed, it can dramatically affect thyroid, cortisol, the HPA axis, immune function. Those monocytes need to be under 7.5, and those white blood cells should be over 6. If not, there's something chronic going on, and so we need to find it. I'm sure I'm preaching to the choir here, but in functional and integrative medicine, we regard cholesterol and to a certain extent blood pressure as a check engine light. When those things go up, we're talking about inflammation. We're talking about a problem deeper in the system. A lot of primary care docs want to treat this, which I understand for risk factor reasons. But if we just have a chance to look a little bit deeper, we can do better for our patients there and really figure out the problem. So we may also need to get into hormone and cortisol testing. We can look for estrogen dominance or progesterone insufficiency, cortisol abnormalities. At that, if you really have a major HPA axis dysfunction, you may need to get into some salivary testing or possibly some urinary neurotransmitter testing as well. The wheat zoomer that this lab does is fantastic for looking at, well, all the different peptides of wheat, but we're going to look at intestinal permeability. Make sure they don't have celiac disease, which would be a monster autoimmune condition, and then we got to keep looking there. And even the non-gluten sensitivities would all contribute to inflammation and therefore cortisol overstimulation and thyroid problem, not to mention the GI issues that could probably go with it. And all the Zoomers for that matter, and the food sensitivity testing is in the same vein. So anything we can do to lower inflammation, especially when we're talking about autoimmune conditions, this would be a very controlled way to do it. We can control what goes into our mouth. The IDS Sure and the gut Zoomer also very great for detecting chronic low-grade infectious problems. And the micronutrient testing. One of the things we discussed earlier is that when thyroid function increases, we have increased demand for vitamin intake. This would give some insight to see if they have enough vitamins available, because you might be able to speed up the thyroid, but then if it slows down another process downstream, then you found yourself a different problem. Now, an iodine loading test might be appropriate for some patients if they have very, very severe autoimmune thyroid conditions, or if they do very poorly on thyroid meds. So we can get into that more, but that's definitely a consideration. It's not one I do all the time, but for some patients, it's certainly more appropriate. So on testing, I hope I don't offend anyone here, either with the TSH meme or with Kanye, but there is so much research out there that says TSH values over 2.0 put our patients at higher risk for future hypothyroidism, especially when TPO antibodies are present. PubMed is all over this. There is a mountain of research on it. And it's really well known that TSH gives us no indication of what's happening in the peripheral tissues. So it's bit of a peeve of mine when patients come in with their yearly labs and are very proud that someone checked their thyroid and it's fine. So a lot of us know better, and we can do better for our patients. Now, that is not to say TSH is not an important marker for screening for thyroid function or for testing our rechecking our therapies, but it is not the be-all, end-all in isolation. Who's seen this patient? I think I did today. So, good. We still have a little bit of time. I'm going to motor through some case studies. All right. First, 35-year-old woman who has never had babies, has some nondescript symptoms and some tummy trouble. She's never had major illnesses. She's not taking any meds. She's taking some really basic supplements, and there was basically nothing on the physical exam. This is what the labs look like. I wanted to screen for, she's menstruating female, nutrition, anemia, and thyroid. So as you can see, the anemia panel looks good. In fact, it looks a little too high. The ferritin level is going up, indicating some sort of inflammation. And the C-reactive protein is also elevated down here. The thyroid, as I just finished saying, TSH in isolation means nothing, but TSH is running pretty darn high. The anti-TPO and anti-QT, they weren't negative, but they're not very high. And that free T4 is a little uncomfortably low. So it's showing a hypothyroid trend. We would agree. We moved on to a wheat zoomer and major gluten sensitivity issues. There was a very leaky gut. There's some potential for some gluten-related skin issues, some immune system sensitivity and hyperreactivity. There might be a gluten ataxia, so a neurological component there. She did have brain fog, and I don't know if I listed it on the last page. So what we did with this patient, we eliminated gluten. We began iodine therapy. We started a spore form probiotic, selenium, and a thyroid glandular. And we retested the diagnostic labs, not the wheat zoomer, but the diagnostics at 6 months. And voila, she feels fantastic on her gluten-free diet. Her fatigue and brain fog disappeared. She's sleeping better. Her menstrual cycles are better. And overall, her energy is good. The GI symptoms completely resolved. No bloating, and bowel movements are nice and regular. That was a fun success story. Let's look at this one. This was a 40-year-old female, dizziness and lightheadedness that she chalked up to anemia. And her chiropractor referred her to me. So when we started talking, she said she was so dizzy and lightheaded that she was falling and fainting at work. And she said she's having very, very heavy periods twice a month. And she mentioned she was diagnosed with Hashimoto's during pregnancy. So during pregnancy, she was medicated, but following pregnancy, the medications made her feel terrible. So she stopped taking them, and she felt a lot better until recently. Her daughter is 7, by the way. And she's having muscle and joint aches and pains, and she has multiple chemical sensitivities. She's the person who can't walk down the perfume aisle, can't put on bug spray when it's needed, those types of things. And she has a brand new complaint, sudden onset anxiety. So this is what she came in with. These were drawn by her PCP a week prior to her seeing me. And with that ferritin sitting at 1, and she received a phone call saying, go buy some iron and take it. So we started her on chelated iron, vitamin C, and she was banned from eating gluten effective immediately. No, I never tested it. But her TSH was off the chart, and I was going to get more, and we have a already diagnosed Hashimoto's thyroiditis, and we started some vitamin D as well. So we drew our lab later in the week, or about a week later. Here's a highlight. She did not have celiac disease, but she had the genes for it. Another good reason to be off of gluten anyway. Her anemia pattern, there it is. Her anemia pattern is changing quickly from the ferritin of 1 that you saw on the prior page, but it's definitely still there. She did have a popped a positive ANA with a titer of 1 to 80, but the ENA was all perfectly with the normal limits, and definitely low vitamin D. So since the first time she saw me, she had several fainting spells at work, and she works in daycare. She was worried about losing her job, and she was at the very beginning of her second menstrual cycle in 18 days, and it was hemorrhaging. So I was able to coordinate her care with a gynecologist in the area that I referred to, got her in really fast, and she performed a DNC, and the patient had a bunch of large uterine polyps that had to be removed. And so we kept her on a regimen, checked her a month later. Here's how it looks. It was probably more like 6 weeks later. The anemia is improving. Her cycles have returned since the DNC procedure, but they aren't nearly as heavy. Still on the heavy side, but not as heavy. Her vitamin D levels bumped up, her CBC improved, and her thyroid autoantibodies did decrease a tick. This is, if we could find a picture of Hashimoto's thyroiditis, I think this would be it. So since these other things are improving and I don't need to worry about her falling on her face, then we are really digging into that thyroid. We started her on a very large dose of a glandular thyroid selenium and a baby dose of iodine. She's feeling subjectively a lot better at 4 weeks. And her anxiety, the new onset anxiety, did resolve completely. She is really, really struggling with a gluten-free diet, but her myalgia and her joint pain seems to flare up now. She cheats and has gluten, so that's been good for her. For the record, I did refer her out for thyroid meds, and she refused. So here we are. We're going to see what the next follow-up tells us. I'll be really, really fast. This is an interesting follow-up because this is that same patient's 7-year-old daughter. She brought her in to see me because daughter was kind of diagnosed, I guess, with precocious puberty. She was evaluated at a major children's hospital in our area, and they didn't do any labs, but she saw a couple of specialists, and they said, let's watch, let's wait, let's see how it goes. So we checked her thyroid, did a diabetes panel, and a CBC, and food allergies and sensitivities. The CBC was unremarkable, by the way. That's why it's not listed here. But we see that this is fasting, by the way. Fasting insulin is sky high. Ferritin's elevated. Hemoglobin A1C at 5.3. I know she's a growing kid, but she's dramatically overweight for her age. So one of these interesting things, that thyroid panel is it's doing some interesting things. Oopsies. As a child, she probably shouldn't have any anti-TPO antibodies, and her TSH is sitting at 2.7, and it was probably higher earlier in the morning. So I'm thinking that there is some thyroid issues starting, but we also found that she had IgE allergies to tuna, brown rice, rosemary, sesame, garlic, and her total IgE was 160. This was her most significant food sensitivity. So what we know about thyroid action on ovaries that can trigger that early puberty, and she's a child, she's 7, we're going to start with diet and see how she does. So we took her off the offending foods, we restricted sugar and gluten, and in 6 weeks she lost 10 pounds and has more energy. She's still very mad at me that she can't have ice cream. But, and on a behavioral note, she came in from out of town for this fasting blood draw, and when she finished her fasting blood draw, she was handed a box of donut holes and a 1-liter bottle of Sprite. So there are some food behavioral things that we're now digging into. She's doing better. Sarah, do you think we have time for one more or no? Oh, well, I'm going for it.
We can go for it. If you have time, I have time.
I'll be really fast. Okay, this next patient, 31-year-old female with a whole host of concerns. Chronic infections, her hair is thinning, that was new. She's been constipated her whole life, very heavy periods, very bad PMS, not taking any medication, but she was taking a variety of supplements, and she's very much about the natural health. So when she would have these symptoms, she would go in to the supplement store and ask somebody for help and get some recommendations, which in some cases was fine, but this was just too much. So her physical exam, her abdomen was tender, her neck was very puffy, and she did suffer from orthostatic hypotension. And the family history was a little bit rough. She had Graves and Hashimoto's on both sides of her family. History of cardiovascular disease, type 2 diabetes, female cancer, and that's just what I listed here. This is what her labs look like. The anemia pattern is very pronounced, and definitely there are a few absorption issues here. So her parathyroid hormone, where are you, parathyroid? There you are. Parathyroid hormone was pretty dramatically elevated, and so that could be due to vitamin D deficiency, but it's something we got to keep looking at since there is thyroid dysfunction here. And the cortisol level, there you are, also very low. And I should note that this blood draw was done more, it was fasting, but more at 10 or 11 a.m. So she'd been up for quite a while. TSH production, very, very low. I would have liked to see her autoantibodies even lower. Free T4 sitting at 1.0, that's uncomfortable. Free T3 is okay, but this is not a picture I want to evolve. So we started her on a methyl B complex, vitamin D, chelated iron. We limited sugar and carb intake, iodine, a glandular thyroid, adrenal support, and fish oil. Yes, her omega-3 index is very low. So this is follow-up. Overall, she's improving considerably. The anemia is almost completely resolved. The vitamin levels are moving, and the thyroid is increasing. We do see that her thyroid autoantibodies are slightly elevated compared with last time. So we're going to dig into some more immune work on her follow-up. And her cortisol lifted slightly, which I was kind of surprised about. Anybody who treats cortisol rhythm issues know it takes a long time to move. So we still have some ground to cover there, clearly. The omega-3s did not improve. The patient admitted she was not compliant with taking her fish oil. So there's that. But overall, she is feeling better. Her fatigue improved. The big thing for her, she's having unassisted daily bowel movements, no choking down fiber or anything like that. And she's no longer cold all the time. Periods are lighter, PMS is still prevalent, but no dry skin. So we increased her thyroid glandular and iodine, and we're going to continue the adrenal work and up that fish oil. So, and she's going to continue on her other supplements. And we have her scheduled for a wheat zoomer in a few weeks to see if that intestinal permeability is there. So I guess the takeaway here would be that thyroid tests should not and really can't be interpreted in a vacuum. We really have to take into account that it's in the context of the whole body, the whole system, and the whole patient. So I hope everyone took one little testing or treatment nugget out of the webinar tonight, and thank you so much for attending. If you want any of these references where I got any of this, I have a reference list that's 2 pages long. Email me.